Thank you very much. And good morning to everyone. So as you heard, I'm talking about TB and HIV. I'm a pulmonologist, so also HIV. I've been working with HIV with children for about 20 years. And so I think I'm the one to advance the slides, if I can figure this out. Okay, good. I have no, I am not a Gen Z. I have no conflict of interest to disclose. Yeah, so I think here the first thing to appreciate is that we have a high burden of both of these. We have a high burden of HIV and we have a high burden of TB. But if you look at TB overall, in 1 year, we had 1.25 million children globally getting diagnosed with TB. And in 1 year, we had 120,000 children diagnosed with HIV. So the burden of TB is enormous. Of course, among TB, we have a percent of them that are HIV infected, and this percent varies across countries. In my country, about 14% of all children diagnosed with TB have got HIV. And I think each of us knows our country presentation. But bottom line, we have a lot of TB. Look at we are still having children diagnosed late with HIV, and you can see the numbers there. And even when they're diagnosed, access to ART is not optimal. Only 43% of children who are known HIV infected are actually on ART. And even when they're on ART, viral suppression is not optimal. Globally, 57% of children on ART are not suppressed. Death continues to take many children's lives. Children should not die. 76,000 children died in 2023. But looking at the TB numbers, you can see that 3 times that number died from TB last year. 1 in 7, and out of those who died, 1 out of every 7 was an HIV-infected child who died of TB. So there's double jeopardy when these two diseases occur together. And if you have a chance to look at this review article that we did, it really covered the topic comprehensively, HIV-associated TB in children and adolescents. I'll just share a snapshot that just from that paper that illustrates how children with HIV are really at increased risk of getting TB. And all age groups. You can see in South Africa, they looked at adolescents and living with HIV, and they had 7 times higher risk of TB than those who didn't have HIV. And this meta-analysis covering 34 countries showed that TB, children who are in families or in households where they're exposed to TB, they had 5 times increased risk of developing TB compared to the children in the same households who did not have HIV. And then even the first year of life, this study in Kenya, where they followed children from birth up to 1 year, they found that even in the first year of life, those children, those babies who are infected with, who are living with HIV, had a 5 times increased risk. So the stark reality of double jeopardy is seen in this Kenyan child. I will share with you, this is a child that we followed up at the National Hospital in Nairobi. He was generally a well, healthy child until the age of 5 years. He lived in a rural setting around the coast of Kenya, very poor family. And he presented to the local county hospital, having been sick for 4 weeks with cough, fever, and night sweats. And his grandmother had recently been treated for TB. So he was admitted into the hospital, and that is the X-ray. You can see there are classic features of TB. There's miliary mottling. If you look around the hilar area, there's opacification showing lymph nodes, hilar lymphadenopathy. And those lymph nodes were enlarged going right down the right bronchus and they were compressing the right bronchus, causing obstruction, and that you can see that the right lung is hyperinflated from air trapping. And the other lung also shows the diffuse miliary opacifications. So good job. The doctors made a diagnosis of miliary TB, and they also did an HIV test. Unfortunately, to the distress of mom and the family, this child was found to be HIV infected. CD4 count was moderately low at 336. So he started TB, he started first-line antiretroviral therapy, and he improved and went home. Now, he was home for about 6 months. He finished the TB treatment, was home for about 6 months, and then returned. He fell sick again. This is now 12 months after his first TB diagnosis. He had been relatively well at home for 6 months, and he came again with a new lung infection. And at that time, he was diagnosed to have pneumonia and readmitted to the same hospital. They gave first-line antibiotics, they gave second-line antibiotics, and he wasn't getting better. And he needed very high oxygen. He was on very high oxygen for several weeks. So they said, okay, this child needs a pulmonologist, which they didn't have in that area. So they put him on an ambulance with oxygen, 500 kilometers to Nairobi, to the tertiary referral hospital where I am. And he arrives and we assess him. And we did this X-ray, and look at that lung. Now, the lymph nodes you can see had resolved. But the rest of the lung, you can see that the whole architecture of the lung is abnormal. Extensive pathology in all lobes of the lung. So we started him, we did various investigations. His expert was negative, and we gave him antibiotics. He would get a bit better. And then, unfortunately, in our hospital, very overcrowded, we have like 20 children in one small room. So he would get better, then he gets a new infection. Then he would get better, then he gets a new infection. And so he was with us for 1 year. And during that time, this was during COVID time, he got COVID. We did a CT scan, and you can see the architecture of the lung. There were huge, very severe destroyed bronchi. He had bronchiectasis. You have areas of complete cylindrical bronchiectasis, circular bronchiectasis, cystic bronchiectasis, a completely destroyed architecture of the lung. And even the interstitium that didn't have bronchiectasis had interstitial fibrosis. So this is a child who, of course, with this very, very damaged lung, there's high resistance to vascular flow. He developed pulmonary hypertension and copulmonale, and he remained very highly oxygen dependent. So my take ultimately with this child is that the damage started long before he even came in at 5 years with TB. And he most likely, as you see in long-term slow progressors, had lymphoid interstitial pneumonia, which was not picked up. You know, he was diagnosed late, and he is not in a place where he'll go for checkups. So lymphoid interstitial pneumonitis can cause, these are lymphoproliferative infiltrates into the interstitium of the lung. And if untreated, you don't get onto ART, eventually you have a lot of fibroblasts and inflammatory cells, and the interstitium gets replaced by collagen and fibrous tissue. So I think this child, looking at the whole architecture of the lung, had LIP, and then he got this bad tuberculosis, and after that it was all downhill. He had multiple infections which caused further damage. And eventually he had very little functional lung tissue. And it was obvious that he needed a lung transplant. We have never given a lung transplant in children in Kenya. I don't know if any other country in Africa has done it, but that was, so basically he was oxygen dependent, and there's really little we could do to him. So eventually we discussed with the family and explained, and had him, he was transferred back to the hospital near home, again on an ambulance, oxygen. It was a well-wisher, a really good Samaritan who was from that Kilifi area, who paid for that ambulance because they couldn't afford it. And I remember they went home to be in the nearest sub-county hospital, still on oxygen, but at least closer to home, where he could see his brothers and sisters, could come and visit him, and mom could also be closer to home. And unfortunately, this young man died 2 years after the initial TB and HIV diagnosis. So this child really illustrates the spectrum of lung disease and how it changes with progressive HIV immune depletion, and how if one gets onto ART, you can survive, the children survive for long, but do they survive with healthy lungs? And here it's a busy slide, but you can see when he came at around 350 CD4, you get sort of the typical primary TB in children, your lymphadenopathy and your hyperlymphadenopathy. But as an immune system, at that CD4, if they get other lung infections, it's a typical pathogenic bacteria and viruses. But as the CD4 gets further depleted, then they start to get atypical type of TB. And in this child, you could see he had a disseminated TB. He had only been sick for 4 weeks. He had really, really severe progression of the TB. And this is unusual in a child who's 5 years old. And then at that level of immune depletion, they may also get other opportunistic lung infections like pneumocystis, cytomegalovirus, etc. You get them onto ART, and they may survive. They may survive the TB, they survive the pneumonias, but they may survive with damaged lungs. So I want to share with you, and then lung disease in children with HIV is not even just the infections, it's much more complex. Living in our environment, looking at that heat map shows how the exposure to particulate matter 2.5, that is sort of smoke particles in the air, is in sub-Saharan Africa is really, really high. We use a lot of biomass, we use biomass fuel, we use firewood, we use charcoal, we use kerosene. That's what people can afford. And throughout these children, from the time they're born, they're on their mom's back in that kitchen, inhaling that smoke. So that continued insult to the lung, then you add it to the TB and you add it to other lung infections, these children are very vulnerable. And then malnutrition. In my country, 60% of children have some form of malnutrition. Malnutrition is very common, and that, again, weakens the immune system, weakens the lung tissue, and so there are multiple insults on top of these infections. And perhaps that's why our children, and some of our earlier papers demonstrated that our children have much more rapid disease progression. The first study I did in HIV, which I did for my MPH, it was before ART, and I found that the children 50% were dead by the age of 2 years. It was a very depressing time for me. That was before ART. And maybe all these factors is what causes rapid disease progression. Here I want to share with you the Breathe Pause study. It's a study I did in the children I've been involved with since over the last 20 years. And I wanted to assess these children in our CCC to see how their lung status is. So we enrolled 320 children and assessed whether they have persistent symptoms. And we found that about 35% had chronic respiratory symptoms or abnormal respiratory finding. The commonest symptom being cough and just shortness of breath with exercise. And the commonest examination finding was they were just breathing faster than usual. And they could not, if you tried to they couldn't walk fast, they would get out of breath, exercise intolerance. And the older children, probably the ones who started ART later, because remember the early days of HIV care, we would wait until your CD4 is in the pits before we start ART. So the teenagers had a much higher burden of damaged lungs. And what were the predictors of these damaged lungs? We found that having had previous TB or having had previous pneumonia, using pollutant cooking fuels, poverty. You can see from the surrogate marker, the number of rooms in the house were all associated with having more likely to have damaged lungs in these kids. So TB is double jeopardy, but it doesn't even end when you treat them and they survive the TB, and their quality of life was really worse than those who didn't have damaged lungs. And this was also shown in South African study where they looked at 100 adolescents who did HRCTs, and they found alarmingly that 70% had obliterative bronchiolitis, 39% had bronchiectasis, and 16% had lung fibrosis. These are adolescents who are on ART. And what was the risk factor? If they had had previous TB, or if they had previous pneumonia, or if they were diagnosed with HIV late. These were the type of children who would have damaged lungs, just like the child that I shared with you. I did a systematic review with others to look globally in low and middle income countries. How common is this post-TB lung disease? And alarmingly, we found that we had 19 studies that reported HIV status, and 1/3 of people living with HIV in these studies across different lower and middle income countries had damaged lungs. So you can see, and what was the risk factor? It was much higher, the highest in Southeast Asia and Sub-Saharan Africa, and also higher in children living in rural settings compared to those living in mixed or urban settings. This review we did in 2023 also looked at paper publications on children with HIV, and their lung function was very low. We can win this battle. We can prevent TB. We should have given preventive therapy to this little boy in the first place, and he wouldn't have been here. And I end with a child I saw earlier this year in my ward. This is a child, again, diagnosed at 8 years. Very, very late HIV diagnosis, and he came in with complete cachexia, marasmic quash. You don't see kwashiorkor at 8 years, and he had messed up lungs like that. So we are still seeing this kind of late presentation and damaged lungs. We must win this war. How can we prevent these infections? When they occur, let's diagnose them early and treat them early. Let's help them to breathe clean air, and if they get severe lung infections, after they finish treatment, let's continue to follow them up and give them optimal lung health care. And together, let's work together to win this battle against TB and HIV and optimize the health of these children. Thank you.